So DVT prevention and treatment, DVT prophylaxis, Sophia, what do we think about when we're thinking about prophylaxis?
So we should be considering every patient that gets admitted to hospital for prophylaxis.
And how do you do that?
And you can consider them for mechanical and chemical prophylaxis.
Yep. And what sort of considerations do you make for who gets mechanical and who gets?
So first of all, mechanical. If you've got somebody who has lower limb pathology, so has an ulcer, an active ulcer or swelling, they probably won't have mechanical prophylaxis on that leg. If somebody is long-term bedbound and never uses mechanical prophylaxis, they may not have it either. But usually most people should be eligible for mechanical prophylaxis. Often with children we don't do it either because they'll be up and moving pretty quickly. And it's mostly about time spent in bed, although even if we're considering an overnight admission, we should have TEDs on the patient.
And you can also add into that arterial supply, whether they've got foot pulses. It's not a absolute contraindication, but if they don't have foot pulses, you might want to get more information as to the arterial pressure in the lower limb. But in terms of, is there any other way to work out who gets mechanical, who gets pharmacological, Lucy?
I guess if they're at a risk of bleeding or they're coming.
Yeah, so there's risk stratification, isn't it? So what's a risk stratification, Jerry?
What is it?
Yeah, for DVT profile.
What is a New South Wales called?
Yeah, go on. And how does the New South Wales health thing go?
How does it go? Well, it looks at your...
Well, there's three categories, isn't there? What are those three categories?
Low, medium and high.
Yes, high, medium, low. Excellent. And what goes into each of those categories?
As in from like the factors that you
exactly. Yeah.
So you think about their risk of thrombosis. So
yeah, okay.
I think so. The types of operations they're having, or if they're immobile, things like cancer as well. So
So cancer goes up here. What else goes up here?
Previous
So what was that?
Previous DVT or PE.
Yeah, probably. That's too hard for me. That's still more specialist stuff. That's fine. That's right, consider it, but it's not in the sort of plain and simple stratification. In terms of plain and simple stratification, I don't know the exact criteria, but basically, if you're walking around and totally well and you're just having your ingrown toenail done, you fit in down here, okay? If you're having a cancer operation or a hip operation or big trauma, you're here. And everyone else fits in here, okay? And admittedly, everyone else, just about most people fit in here. Most people come in, they've fallen off their bike or horse, and they don't have cancer, they're not having major trauma, or someone comes in with their appendix and they're young and generally fit and healthy. Again, they don't have cancer. They're not going to be in hospital for ages and ages. Most of our people fit in here. Okay, so let's get rid of that for the moment. What does New South Wales Health recommend for high risk for prophylaxis? Cameron?
So is it mechanical and chemical?
Yeah. So mechanical, yep. And pharmacological. So pharmacological, what options do you have here?
So heparin.
Heparin, yeah. How much?
5,000 international units BD.
Yeah. Now this is where I don't like the New South Wales Health guideline. For both high and medium, they say 5,000 units either BD or TDS. But I was taught that if you're high risk, then you give that TDS, and if you're medium risk, you give this stuff BD. And I think that makes a little bit more sense. If they're high risk, you give more of it. And you give mechanical, as you said. So what else can you give for pharmacological practice?
Tensional stuff, transferrin break.
Pexone, how much?
40 milligrams.
Yeah, 40 milligrams. Once a day, subcut. I'll give them that rather than stab someone 3 times. That's has it stopped?
Stop recording.
Yeah, sorry.
After the phone call.
I just restarted it.
Oh, thanks.
Just jump.
So the recordings missed it. What we pointed out, Cam, was that the nurses like this rather than this because they don't have. This is pre-prepared. The nurses have to break an ampule to administer this. This costs in a few dollars. This costs in a cents. So there's that. Medium risk. What's the recommendation there? the one I read most recently was it's mechanical or pharmacological. Now this is where we tend to differ. We give everyone in this category both, and I think most surgeons are going to continue to do that unless there's good evidence to say that there is harm done by giving both in this risk category. Okay. How much Clexane do we give here?
40 milligrams daily supper.
Yeah, look, I think that's a recommendation. I think when Clexane first came out, they just recommended 20 once a day with the mechanical to differentiate it from the high risk category. But I think more and more, I'm just going to give everyone 40 milligrams once a day down here as well, if I was going to use Clexane. If you want to use heparin, I'd use 5,000 units BD. And down here, it's just mechanical and encourage mobilization. So that's that. So you know all about DVT prophylaxis now. How do you treat a DVT? Sophia?
So you can treat it with the same medications that we were just talking about, so heparin or Clexane.
Well, the question is first, do you need to treat it?
That's a good question.
When do you need to treat a DVT?
So there are patients that fall again into high risk, probably medium and low, but if there's the risk of a DVT is it propagating and embolizing and becoming a PE. So particular ones that are above the knee or into the pelvis are high risk for embolization to the lungs and causing a PE. So you certainly have to treat those.
Yeah, so definite treatment for above knee and above elbow.
Yeah, that's true. Upper limb as well. Yeah, and pelvic. Yeah,
So anything above knee, above elbow, you have to treat.
Yeah.
Anything below the knee or below the elbow, it's sort of up for debate. Generally, people give you treatment for 10 days and repeat scan or something like that. You can ask for a specialist opinion in your particular institution. So generally, if someone asks me, that's probably what I'd do. So if there was below knee or below elbow, treat for 10 days, repeat scan, and then go from there. These you definitely need to treat. And treatment is for how long?
I think that depends on the underlying etiology.
Yeah, somewhere between 3 to 6 months, depending on other
Or
circumstances.
indefinitely if they're unprovoked.
Yeah. So how do you treat it? Lucy?
So therapeutic Clexane or heparin.
Yeah.
So with therapeutic Clexane, it will be weight-based, so it will be 1 milligram per kilogram BD or 1.5 milligrams per kilogram daily.
Yeah. So that was, just for the video, that was 1 milligram per kilogram once a day, or 1 point, if I can get my pen to work, 1.5.
It might be just a bit wet.
So but you get an idea what the dosages are involved. So if you've got a 70 kilogram person, what sort of dose would you give to that person, Jerry, if they had a known above knee DVT?
For the
Thanks,
for the
Sophia.
Clexane.
Yeah, and you want to treat it,
1 milligram per kilogram.
which is,
70
yeah,
milligrams.
all right.
And BD.
And how do you administer that?
Clexane is subcutaneous.
How would you chart it in the chart?
Not sure. I would,
Cam?
Yeah, you go.
That's a true question.
I would have thought it was just chart.
Yeah, we just tried it.
So if someone weighs 73 kilograms, you're going to chart Clexane 73 milligrams
there's a-
subcut
I think
twice a
there's
day.
I see what you mean.
Yeah, there's an 80 milligram preparation.
Yeah, you get vials in 60, 80 and 100. And as you know, it's a pre-mixed thing. It's not as if the nurses are going to specifically draw up 73 milligrams for a 73 kilogram person. So you just got to use a bit of judgment and round it up or down. And you probably would round up more than round down.
Especially depending on habitus, I imagine.
Yeah. One of the issues I didn't discuss about DVT prophylaxis in surgery in particular, the anaesthetists always like to have the option of giving an epidural for all sorts of things. So generally, particularly for elective surgery, don't give the subcut heparin before their surgery. They can always give it at induction after the anaesthetist has worked out whether or not they want to give an epidural and stuff like that. And even, I used to get really worked up about the fact that nurses withheld the heparin on the day of surgery because I didn't think it was necessary. But again, for that reason, that same reason, I think it's probably reasonable to do. To give their anaesthetist the option of giving an epidural or a spinal or something like that. Now, still on treatment, we've talked about clexane for treatment. What other agents can you use to treat a DVT or a PE for that matter? Sorry.
Oral agents.
Yeah, such as.
This is warfarin.
Yeah. How do you give warfarin?
So you need to have close monitoring with INR, and
Yeah,
you'd
what-
also
Ballpark figure: 100 milligrams a day, 200 milligrams a day.
like 1 to like 3. 3
Sorry,
milligrams a day.
1 to 3 milligrams. Oh, good. I'm glad someone knows this stuff. No, I'm sure you all know it. But for
And
medical
targeting
students,
an
they need
INR.
to know ballpark. Yeah.
Targeting an INR of 2.
Yeah.
Not always for DVTs.
Okay. What other oral agents can you use?
The novel.
Yeah.
is novel.
And I'm not a specialist there, so go talk to Dr. McCready or someone.
Thanks for
Okay.
that.
What other agents up here can you use?
Heparin.
How much heparin do you give? Philippa? Yeah.
Yeah.
But I'd like you to have a general protocol in your mind so that when you go to different hospitals and they've got different mixture regimes, you have a ballpark.
It was like
Sophia,
Um,
100,000, 200,000.
no, like around the 5,000 to 10,000, I think.
There's like a 5,000
So,
unit low dose, and
It's
then
usually
like
5,000. I think that for the average person, it's about 5,000 stat
And then like 18.
and then 1,000 per hour. Okay? And if you have that as a ballpark, and then you sort of adjust it up or down depending on how big the person is, that will stand you in good stead. Because you'll go to different hospitals, and some hospitals will put 10,000 units in a 100 ml bag, and that turns out to be I don't know how many mils per hour. And then another hospital will have 25,000 units in a 50 ml bag, and the the infusion rate in mils per hour will again be different. But if you convert it back into units per hour, and it turns out to be around 1,000 units per hour, then you're on the right track. Okay. So as a ballpark, 5,000 units stat, 1,000 units per hour.
And I think you're targeting an APTT of about 60 to 100 from
Yeah.
memory, so that you just monitor that regularly,
Yeah.
and then you can up your titration of infusion.
Yeah.
So that's the other thing, the heparin's an infusion, not a...
Yeah,
Yeah.
it is an infusion.
Yeah.
Now, if you did that for 24 hours, how much heparin would they get?
29,000.
Yeah,
Yeah,
29,000.
about 30,000, yeah.
And just as a curiosity thing, if you gave DVT prophylaxis at 5,000 units TDS, how much would they get over 24 hours? They'd get about half of that, wouldn't they? Okay. So, ballpark, you've got a comparison of that. Any other treatments for DVT if for whatever reason you can't anticoagulate? Do they need urgent surgery or something? Yeah, an IVC filter. PE treatment, same as DVT treatment. What's the indication for cardiothoracics and lysis to be involved? Yep, good. Were there any other questions or queries about DVT prophylaxis and treatment of DVTs and PEs?